Alaikum, good evening everybody. My name is APR17. I'm a neurosurgeon and we are transmitting live from here in Amman, Jordan, from the Farah Medical Campus. And our topic for tonight is this third time surgery for vestibular schwannoma. Twice it was done outside Jordan. Lessons that we need to learn from this. This is the spring in Jordan.
How lovely.
This won a major prize. This was done by a Jordanian photographer, amateur, and he called it Tel Tabiz of Jordan, like the comics.
Which area?
North of Jordan, Al-Qura. So just watch this beautiful view.
Wow.
And this is the black iris, which is the symptom of Jordan. So schwannomas. We're talking about schwannomas. What are these schwannomas? They are tumors that are derived from Schwann cells. And all in all, the schwannomas constitute about 8% of all the brain tumors. Commonest type is vestibular schwannoma, schwannoma arising from vestibular nerve. About 90% of schwannomas are vestibular schwannomas. The other 10% are non-vestibular schwannomas from other nerves. So non-vestibular constitute 10%, vestibular constitute 90%. Oculomotor schwannoma, abducent nerve schwannoma. Here I'm presenting my cases. These are not cases from literature. These are my own cases. Facial nerve schwannoma in this Iraqi lady. Schwannoma that arise in the jugular foramen, which means that they are either schwannomas of the glossopharyngeal or vagus or accessory. And here one of these accessory nerve schwannoma, a young boy from Jordan. And this hypoglossal nerve schwannoma. So vestibular schwannomas, 90%. When you mention vestibular schwannoma, you mention Professor Majid Sami. He is the man of vestibular schwannoma in the world. He has done something like 5,000 cases, the highest figure in the world. And Majid Sami,
is the location?
he's in Hanover, in the International Neuroscience Institute. He's a friend, a close friend of me and my family, and he's a close friend of Jordan. Here he is with late Dr. Ishaq Marakha. We visited his center many times. He's a frequent visitor to Jordan, and both we were in the World Federation of the Neurosurgical Societies. He wrote most of these papers that one quotes. This is one of his papers, and in it is said the philosophy of senior author, which is Majid Sami, is that all cases of vestibular schwannoma, irrespective of their size, complete surgical removal and preservation of the facial nerve is the goal. You say this, and some people would say gamma knife. I will allude to this. This paper about surgical removal of giant vestibular schwannomas. Giant means that more than 4 centimeters in diameter in the very small posterior fossa. It's really risky. And his results about the facial nerve, because of the size, you cannot save the facial nerve. In his hands, 25% lose totally the function of facial nerve, 25% fair function, 50% equal to good. But what is good in his hands is not good in the others. He also wrote papers about where do you find the facial nerve. You find the facial nerve always anterior to the schwannoma. And that's because of the location of the facial nerve. So this is the vestibular schwannoma on the left side. This is pons, this is cerebellum. Facial nerve should be here, like this. It's always anterior, superior. It could be anterior, inferior. It could be anterior in the middle, but usually anterior. So he classified it, and it is known as INI, International Neuroscience Institute of Hanover, or SAMI classification. By the way, his son is a neurosurgeon. And I remember Professor Sami, carrying my son Aziz when he was 3 years old. And I captured this on a camera. And I will leave it to my son to say that he was carried by the most famous neurosurgeon in the world. So the size of these schwannomas, whether they are completely intracanalicular or 1 centimeter diameter, 2.5 centimeter, more than 4 centimeters in diameter. So we speak about this small size within the canal, coming out of the canal, or large like this, and how they take the arachnoid with them. We've learned all this from Professor Sami. So he classified them into type 1, where the tumor is inside the canal, totally inside the canal, small. Here it is intra-extra, so it has come just outside the canal, just bulging here, called type 2 or stage 2, or 3 divides into A and B. 3A is coming out from the canal, but it's not pressing the brainstem. There is still some space there. 3B, it is touching the brainstem. 4A, it is compressing the brainstem. 4B, it is compressing severely the brainstem and distorting the fourth ventricle. And 5 is the giant, which is really crossing to the midline and forming all this. I'm lucky to have these giant tumors. Lucky because people do not want to operate them, so they throw them at me, and I take them with pleasure. Some people don't even do the small ones, and they refer them to gamma knife. I will still allude to that and tell you my philosophy. Not all the vestibular schwannomas are solid. Sometimes they are cystic. This is an Iraqi man, 36 man, with a bullet in his abdomen due to the war in Iraq, so could not do MRI. And we were satisfied with this CT, and his tumor was almost cystic. I call this triple pathology. It's the only case reported in literature where you have 3 pathologies. This is arachnoid cyst on the left side. On the right side, you see 1 tumor. Actually, when I operate upon them, this was vestibular schwannoma. This was a trigeminal schwannoma. So extremely unusual. What's the relationship of the vestibular schwannomas with the internal auditory meatus? You just see this. I call it timsah, mouth of a crocodile. If it opens, this means that there is something inside. So these are symmetrical internal auditory meati. And when you finish, you see the jugular foramen. So one has to differentiate between jugular foramen, which is here, and the internal auditory meatus. Again, thorough knowledge of the temporal bone is essential here, especially for a skull-based surgeon like myself. MRI is beautiful, and it shows you the internal auditory meatus, shows you the semicircular canals, shows you the cochlea. So details, where is the ica, where is the pica, you can see all these relationships. In the coronary view, you can see this. You can see the superior semicircular canal, the lateral semicircular canal, and the posterior semicircular canal. This is jugular. Here, in this case, this internal meatus is normal. This is wide. So the mouth of the crocodile is open. Something in there. Completely destroyed. Vestibular schwannoma could be bilateral, and in this case, we're talking about neurofibromatosis type 2. Bilateral schwannomas constitute this disease, which is genetic. It could be small like this, it could be giant like this, it could be multiple tumors like this. All these cases are my cases. And maybe in the future we'll present some of these cases of neurofibromatosis type 2. Again, look at how much brainstem is left here in this NF2, or this here. Trigeminal schwannoma, bilateral vestibular schwannoma, multiple tumors, etc. It's a bad disease. What's the differential diagnosis of a tumor in the cerebellum-pontine angle in addition to vestibular schwannomas? Many. I'll just put this off. So, coronal plexus papilloma coming from the lateral recess going to the CP angle, hyponeurocytoma, thrombosed aneurysm, and people who thought this is Rare, last week we had basilar aneurysm situated there. Melanoma, metastases, primitive, and large cell medulloblastoma. So medulloblastomas are not usually more in midline. They could be lateral, presenting like this, like cerebellum-intine angle, like a vestibular schwannoma. Lymphoma, ependymoma, clivoscordoma, metastases, glomus jugulare, and lipoma. Hemangioblastoma, chondrosarcoma, retroclival meningioma, cholesterol granuloma, endolymphatic sac, this is one of my cases in a Sudanese diplomat, and atypical teratoid. And of course, the epidermoids. Most aneurysm, as you said, and Berger disease. Trigeminal schwannoma and metastasis. In fact, I want to go back just because of Alaa came in here. I wanted to ask him about something. We were mentioning that when you speak about trigeminal schwannoma, about vestibular schwannoma, we speak about Majid Sami. Is that you, Alaa?
Yes, that is.
That was 2005.
Actually, I was sworn that was me.
Yeah, it is too. Yes. So I meant to ask you about this. So
You're done with the differential diagnosis part?
no, yes, we did.
May I comment on that?
Sure, yes.
Who was that?
2005. This is the panel.
2005. Yeah, so this looks like schwannoma, and radiologically it's quite characteristic. I just want to point out the diversity of things that would mimic this and the implications of this from oncological perspective. Melanoma, yani you would not even imagine that. We actually have seen cases like this. This would be metastatic melanoma to the brain with whole different implications to the choice of treatment that you would give, because we have a lot of agents that would penetrate the blood-brain barrier nowadays in the treatment of melanoma. Medulloblastoma is on the differential, and the importance for this, thank you, and the importance for this, okay, and the importance for this is that the treatment after the radical surgery may be radiotherapy or platinum-based platinum-based chemotherapy, and the treatment has to have radical excision in the beginning. Lymphoma, and I can't emphasize this enough. If there is no evidence of lymphoma in the system, that would be primary CNS lymphoma. It can happen in this location, and the treatment would be based on high-dose methotrexate with an attempt of delaying the radiotherapy till later. Ependymoma would be approached in a manner of maximal excision, radiotherapy that used to be whole neural axis radiotherapy, plus minus cisplatin-based chemotherapy. Chordoma, apart from surgery and or radiotherapy, there's little we can do. I cannot emphasize the importance of ruling out a metastatic disease because nobody bothered to examine the patient properly, because the implications for treatment would be dramatic. Chondrosarcoma, apart from good surgery, there's really little we can offer, but the whole natural history would be radically different. Apart from the non-oncological cases to start with, like thrombosed aneurysm, metastatic nasopharyngeal carcinoma is important to identify because the treatment is going to be radically different, and after surgery it's radiotherapy with concomitant chemotherapy and chemotherapy after that if it's nasopharyngeal, and if it's not nasopharyngeal, non-nasopharyngeal EMT disease, it would be treated with concomitant and then chemotherapy with a less intensified regimen. The metastatic nasopharyngeal would be treated in a manner that would have concomitant cisplatin-based chemotherapy with the radiotherapy and then cisplatin-based chemotherapy. These are actual cases. It's not just a mental exercise of what potential could this be. And I'm sure Professor Ibrahim has mentioned this already. The common crime of subjecting this patient to a stereotactic radiotherapy, burying the evidence without contemplating what this could have been, is just, we continue to hammer this point on a weekly basis, and this crime continue to happen on a daily basis. Thank you.
So what is the management of vestibular schwannomas? There is one line of, we call it wait and see, especially if you have a small intracanalicular schwannoma and the patient wants to wait. You can offer to wait and keep doing the frequent MRIs, or you can give gamma knife. And I keep saying this. I was the first man in the Middle East back in '96 to treat, and this was actually a vestibular schwannoma lady who refused totally the surgery. I was able to do the surgery. I'm not biased to the gamma knife. So I said, you have surgery, you have gamma knife. I don't want anything related to surgery. So I gave her gamma knife, which is a poor indication, by the way. And I always felt a fool with a tool is still a fool. You don't just treat everything with gamma knife. This is a crime. Just because you are a mediocre surgeon who cannot operate on cases. And these are some of the examples of cases treated with gamma knife. This is female, Jordanian, 17-year-old, bilateral schwannomas, treated the big one with, these are the fiducials, this is gamma knife, treated with gamma knife. And look at this. This is the schwannoma, this is the other schwannoma, and look at this. I thought maybe this is just growth of this. Actually, it turns out that this is a meningioma that developed on this as a complication of meningioma. So this is the original schwannoma, and this was the meningioma. This is an artist illustration here.
This is after the gamma knife treatment. This
is after the gamma knife treatment, yes. So gamma knife can cause tumors and can cause malignancy. You can see it. This is sitting on top of this. These are the fiducials. These are the azure doses of the radiation. So what should you do? I went in and removed this huge mass there. Another case from Syria, 63-year-old man with this schwannoma that was treated with gamma knife. There you see the fiducials. 3 months later, it got swollen, causing brainstem and hydrocephalus. So I took him to theater and I removed it. But it was hell of surgery to do. So surgery after gamma knife is hell to do. And this is not mentioned to the patients by these doctors, by these mediocre doctors. But I will give you gamma knife, you will come in the morning, you will leave in the afternoon, it will just vanish. Nobody is honest to tell patients that if you need surgery, and this can happen, it will be hell of surgery because you cannot see anything. Everything is amalgamated. And this is the histopathology. This is Dr. Farsakh. Acoustic neuroma with secondary radiation changes, fibrosis and necrosis. So surgery is the mainstay. And this is a view of the trigeminal nerve, the facial nerve, the icon, the lower cranial nerves at the end of surgery, if you are good enough. And this is the disease, the Jordanian disease, the Arab disease, the third world country's disease, shunt. It's, they just use it as SKB from doing these surgeries, shunt. No reason for it. And they claim that we have done it in the middle of the night because the patient was going off, so we saved his life. We can still save his life with external drain. We don't need to put a shunt in. My series of these giant vestibular schwannomas. All in all, I have 664 cases, which is small in comparison with Majid Sami, who has done 5,000. But I'm proud of this figure, and I'm proud of this more. Giant ones, more than 4 centimeters, is 72 cases. This is one of the highest records of giant vestibular schwannomas. And I'm proud to say that I had only one mortality in these, 7 morbidities in these, and I only could save partially the facial in 4 cases. Once you have a large size, you will not see the facial nerve. You cannot preserve it.
متى تحدث المورتاليتي؟ بعد العملية.
During surgery or after surgery? Because you are going into the stereofossa, brainstem, so everything is critical there. I'll show you some of these cases, and these are my cases. And you can see they are real giants. I put those cases which I followed actually. The cases which I lost for follow-up, I did not put.
And you did total removal.
Yes. That's the idea. They are well encapsulated, but you have to know your techniques and you have to know your anatomy well. I must say I had one case from Palestine, which was treated there by surgery. And the lady was told that they had removed the tumor. When she came my way, the tumor was still there as it is. She paid $30,000 for that. Without mentioning the hospital, she had the surgery in, and I had to go in and remove it, except for a small removed tumor that was attached to the brainstem. So sometimes you have to leave a little bit of remnant.
And would that reoccur?
It can, yes, of course. So this is the coronal picture. Whenever I have such a case, I don't sleep that night because I know I'm facing a disaster of surgery. Examples: 20-year-old female with this giant. This is immediate post-op. And this one, giant, immediate post-op. And this very giant, immediate post-op. So back to our case for tonight. This lady who had 3 surgeries, 2 of them outside Jordan, and she came to us for advice. This is an Iraqi lady, 29-year-old, beautiful young lady, with her husband and sister. In Iraq, she complained of headaches for the last 6 years. Again, mentioning how very little knowledge we have as doctors, and we are treating patients with this very little knowledge we have. 6 years, nobody bothered to look into her funder to take good history. She was diagnosed as migraine simply because she's a young lady. So she must have a migraine. Then she had started to have hearing loss. Hearing loss in a 29-year-old means one thing: vestibular schwannoma until proven otherwise. Nobody bothered to do MRI. They have given her hearing aids.
Was it unilateral or bilateral?
Unilateral.
Hearing aid.
Yes, in Iraq. Then she started to have dizziness, imbalance, and blurred vision. And that's when somebody thought, oh, let's have an MRI. So the first brain MRI was done in Iraq, was done in September 2018. 18th of September 2019. And it is reported as about 3.5 centimeter diameter thing. So this is the MRI, giant one, it's a large one. And most important, it's causing edema of the brainstem and cerebellum. And this is a bad sign. With some hydrocephalus. So you can see. That's why she had blurred vision to start with. So she had hydrocephalus. And hydrocephalus can occur because you are blocking the fourth ventricle, or because the vestibular schwannoma, they secrete some proteinous material into the CSF. Here's the starting of the story, saga, soap opera. Bear with me. She left her country, she went to another country, which we will not disclose. She had surgery, left retrosigmoid approach for this lesion, 26th of September 2018. outside Jordan, 11 hours surgery. And if you look at the notes of the surgeon there, I will read it for you. During resection of the tumor at Pons, so supposedly, according to the description, the surgeon was at the pons and medulla oblongata. She had decreased SAP's potential. At that point, I decided to terminate the operation after 11 hours. And when the patient woke up, she was told, we have removed your tumor. The following day, she was told, oh, we have looked at the MRI, and there's still some residual tumor. Imagine this is residual after 11 hours. And I meant to invite Dr. Hadidi because this is malpractice. And we are coming to malpractice in Jordan in a big way. All the tumor was taken as this small portion and nothing else. The surgeon was not at all near medulla or pons. So the following day, the patient told, oh, we have small residual tumor that will take for you. So she had another surgery 2 days later.
By the same surgeon.
By the same surgeon, the same hospital, 28th of September. 28th, even the date was not written well. 7-hour surgery. I will read the operative note. The facial abducent nerves were removed, the residues around the basilar artery were removed. And due to bleeding from the brainstem veins, the mass and the brainstem was excised, and the patient developed asystole for a few seconds, but immediately returned to normal sinus rhythm. Again, the reading of the note. I removed, that's the surgeon, the supratentorial part of the tumor, but during the attempt to remove the brainstem part, she had deep bradycardia, almost cardiac arrest. This is an excuse of failure, of mediocre surgery, to say the least. And
Not even write Arabic. He writes dot instead of dot.
yeah, this is yes, exactly. Now this is actually the writing of the patient's sister. This is what they have been told, and I'm just copying it. تم استئصال القسم الكبير من العظم. We have removed the major part. I mean, the surgeon is telling the family, we have removed the major part of the tumor in that area that is pressing on the brainstem. You can leave in 2 days. You can go to Iraq, and the tumor will be followed regularly. Another frank malpractice. So the patient arrived to Jordan in December, and the tumor is the same.
Actually bigger.
And the opening of the bone is not good because you have to come here so that you will not do cerebellar retraction. You have to come very close to the sigmoid sinus. So if you do this, you have to retract the cerebellum more. So the opening was a work of an amateur. This is the MRA, and I looked at the MRV here in Jordan, in this hospital, and I found that the left transfers and sigmoid sinus are not seen, are not visualized. So I called the surgeon and I said, have you done MRI before surgery? And the answer was no. Imagine somebody is doing posterior fossa surgery without doing MRV. Either they have done it and they don't want to show it because they have a problem, or they have not done it. In either case, there is a problem there, closed in the site of surgery. So maybe they had some bleeding from there, and that's why the surgery was aborted. So when she came, she was 15/15, but she had cerebellar signs, impaired finger nose tasting, tandem walk was impaired. She was bleeding to the left side. Young, beautiful lady in disarray. So we did a few consultations. Dr. Ibrahim, are you here?
Good evening. So basically, you see the images. There's a space occupying lesion, and you see what you look for. With these lesions, we look for papilledema, and other signs. Actually, this patient had in history what we call TVOs, transient visual obscurations. When she is sitting and she stands, she loses vision for a few seconds. So she had that. And her vision is good, while her fundus is not. She has swollen optic disc with with this OCT showing. Okay. So her vision is good, everything is good except for her optic nerve, which is swollen. And with this OCT, the color code of OCT is whenever the nerve is swollen, it gives you a white color. It is swollen. Whenever it is normal, it is green. And then we have the yellow and red, which is thinning. So it is swollen, and you can't see this, but in our clinic we see something because we see 3D vision by our lenses. So you see the optic disc is like this. It's a mushroom-like. That's what why they called it papilledema. So that was the case. The same thing. Fortunately, whenever we evaluate the optic disc, we evaluate also the retina. Whenever you see the retina is good, there is no a lot of red color here in the retina, that means that she can regain good vision after surgery. So that's what we tell the surgeon and the patient. And this is the other eye. The macula was good, with good contour. And that's it. Okay.
Because of hearing loss, we asked Dr. Mohammed Al-Assad to see you. Do you want to make comments, Mohammed?
Yes.
موجود. نخش على الأوديوجرام.
قبل ما نخش على الأوديوجرام for an ENT we have a long history of dealing with what we used to call it acoustic neuroma. Now they call it vestibular. This is really give me a history. معلش بدي أطول عليكم شوي. مع إدنبرا اللي هو وين إبراهيم تتمرن في النيوروسيرجري. كانت المشكلة معنا قبل ما كان في لا سي تي ولا MRI ولا بي ولا دي ولا إكس. كان في بس الماكسيموم توموغرافي. وكان مطلوب مننا نشخص الأكوستيك نيوروما والفيستيبولار نيوروما بالتست بتاعت الهيرينج. كان عندنا شيء اسمه ريكروتينج تيست اللي هو نحاول نفرق ما بين الكوكلير ونون كوكلير وبالسنسور نيورون. كنا نعمل المالتيبل تيست كلهم ونبعث للنيوروسيرجن نقول لهم والله احتمال كبير جدا ان تكون اكوستيك نيوروما. يقول لك طيب اذا ما بينتش بالاكس راي كيف how I justify to do the surgery؟ طب ليش تبعث لنا؟ هذه الهيستوري. لانه في مثل بيقول لك باي نظام باي شيء if you don't know the history of what you are doing you will stay as child forever. لازم الواحد يعرف شو ما قبل الاشياء اللي هو بيعملها علشان يقدر تماستر الاشي اللي بيعمله. معلش نكمل بس. as you see ما فيش عندنا اشي اسمه dead ear، في عندنا اشي اسمه non recordable hearing test اللي هو في الجهة الشمال ما في أي ريكوردينج، وبالتالي ما نقدرش نقول إنه dead ear. وهي الأشياء اللي هي الرونج بتاعتنا. هذه هي الأشياء اللي إحنا بنحكيها هنا مثلا لحد 120 اللي هو الريكوردبل بتاعنا. هلا إذا ما سمع أكثر ما سمعش على 120 معناها بنقدر نقول non أو very severe non recording hearing. اليمين كويسة. الإشي اللي أثارني إنه بيحكي إبراهيم إنه كان عنده hearing loss وشوي بعرفش كام واعطوها hearing aid. There is no hearing aid for unilateral hearing loss. And when we give a hearing aid, we give to the bitter ear. لأنه المخ بيستوعب الصوت الأعلى. فأنا لما واحد عندي يكون سمعه شوي نازل ما بقدرش أعطيه hearing aid لأنه حيصير يسمع بدانه الكويسي الصوت العادي وبدانه الثاني الصوت بميكروفون. ما فيش حدا منا بيحب يسمع إني أنا أحكي معه كلمتين بالميكروفون هذا وبعدين أحكي معه هيك. بقول لك يا أخي يا بتحكي لحالي يا بتحكي بالميكروفون. لأنه في شيء اسمه باك جراوند نويزز اللي هي تؤثر على السمع. شكرا.
I wonder how our international audience will deal with this Tulkarian accent.
بتشاف مش عشان من كده
ولا احلى منها.
Sir Muhammad?
Okay. Actually, this patient hasn't diabetes at all. When we did HbA1c for her, she has impaired glucose tolerance. HbA1c, it was around 5.8. But she has a past history of gestational diabetes and she has polycystic ovary syndrome. Such patients, they are prone for exacerbation of diabetes during surgery, particularly during high-dose steroids. I prepare a few slides just to show who is the category of patients who are prone for exacerbation of hyperglycemia during surgery and during high-dose steroids. Of course, well-known diabetes, patients with pre-diabetes, impaired fasting glucose, impaired glucose tolerance, patients with metabolic syndrome, previous history of gestational diabetes, patients with polycystic ovary syndrome, patients with abdominal obesity, acanthosis nigricans, patients with acromegaly. Our patients actually, as I mentioned, she has impaired glucose tolerance and history of gestational diabetes and polycystic ovary syndrome. Categories of prediabetes, as you know, there is 3 categories: impaired fasting glucose, when fasting glucose above 100 and less than 125. This is impaired fasting glucose. Other category, which is impaired glucose tolerance, it is when random 2 hours random blood sugar, it is between 140 and less than 200. And when HbA1c, the third category, when HbA1c between 5.7 and 6.4. A lot of colleagues, they are a little bit underestimating this category. You don't have, okay, 5.8, you don't have diabetes, but actually when they are subjected to high-dose steroids, there is a flaring up of hyperglycemia. This is the IDF criteria for metabolic syndrome. Just to remind you, metabolic syndrome, the essential diagnostic criteria, it is abdominal obesity, and the waist circumference for men, it is above 90 centimeter, and for females, it is above 80. The triglycerides should be above 150, HDL below 40 for men, and below 50 for females, blood pressure above 130 over 85, and fasting glucose above 100. 2 of these, if they are coexist together, you are diagnosed with metabolic syndrome, which is very common. In US, it is estimated that metabolic syndrome accounts for 50% of population age 50 and above. Other conditions associated with the metabolic syndrome: non-alcoholic fatty liver, hyperuricemia, and obstructive lung disease, sleep apnea. I will just summarize the basic principles for management of hyperglycemia during steroid therapy. The goal is to keep blood sugar between 140 milligram deciliter. It is considered the most best figure which associated with the least morbidity and mortality. But of course, if you can avoid hypoglycemia. If you cannot avoid hypoglycemia, you can extend the range from 110 to above to 180 milligram. It is very safe range during surgery and inpatient management of hyperglycemia. Frequent monitoring of glycemia is essential, at least 4 times a day. We do not use sliding scale regimen at all. This regimen should be discouraged, as in a previous lecture. Only lazy physicians and or who do not know the pharmacokinetics of insulin still use this old-fashioned approach. We use usually basal bolus insulin, and we usually calculate the dose according to body weight, and we divide, of course, those basal insulin 1 shot in and regular insulin 3 shots before main meals. All of these should be associated with proper meal plan. I usually write in details how much calorie. I calculate the calorie for ideal body weight, and I divide the meal plans into 3 meals and 3 snacks to avoid hypoglycemia during high dose insulin. Dosages of insulin should be calculated according to body weight. Dose escalation is required according to response with every high base blood sugar reading. If I have enough time before surgery and after surgery, I add DPP-4 inhibitor plus metformin and SGL2 inhibitor on top of insulin regimen. This adding oral hypoglycemic agents on top of insulin will reduce the total daily dose of insulin, will reduce the risk of hypoglycemia, and you achieve better glycemic control within short period of time. If there is no contraindication, I mean normal kidney function, normal health. With this approach, we can control glycemia within 24 hours up to 48 hours. On day of surgery, either we use dextrose saline according to if there's a high hypertension or not, from 0.18% up to 0.9 if there is no hypertension on the baseline. Of course, we add the KCL to avoid hypokalemia during surgery. If the calculated dose is too much or unstable glycemia, this is another approach, is to use insulin infusion pump during surgery. Of course, you have during surgery to monitor blood sugar every hour to avoid hypoglycemia. Thank you.
This is very important because we see these problems all the time. And from last time, we agreed that sliding scale is something of the past. It should be discouraged. I asked Dr. Khaldun Haddadin to see the patient. Why? Because this is the 3rd surgery that we are going to do. This is a giant, large vestibular schwannoma. The chances of preserving the facial nerve is almost nil. In addition, that previous surgery would have caused adhesions. So to me, it's impossible to save her facial nerve. So I asked Dr. Haddadin to do the tarsorrhaphy for her in preparation for follow-up after surgery. He apologized for tonight because there's a meeting somewhere. Dr. Faras Abaisha, as the anesthetist, he asked for some chest physiotherapy, and he declared patient is fit for general anesthesia in the sitting position. Dr. Mawiya, do you want to say something? And I want to ask you a theoretical question for the audience. We are going to do this surgery in the sitting position, and supposedly that now we develop air embolism. What should we do?
Thank you very much. Assalamu alaikum. Yeah, before I'll answer that question, please, I want to go back to some slides where Dr. Ibrahim alluded to the previous 2 surgeries. Remember in the first surgery, he mentioned that she had major bleeding and then they have to stop and run away. The second surgery, she had almost cardiac arrest, and they have to close. Sorry. And again, they have to go away. And he mentioned about incompetency, and I think incompetency not just by surgery. I mean, this, not just this surgery. All surgeries are success of surgeons by a good anesthesiologist, by a good, and the patient is safe going back home by well and good preparation. I think today, وخاصة Dr. Mu'min هون يعني there is no place for such a thing to happen nowadays. All patients, all critical patients, they must be seen days before anesthesia and before surgery. They must be evaluated very well. They must be investigated very well. And then you will accept to do the surgery in that day, in that moment, in that hour. It's not acceptable anymore in this country after all this, for these major cases to come and show up, and you show up in the morning. صباح الخير أنا الدكتور فلان لا طبيب تخدير بدي أكون معك اليوم الصبح. This specific surgery in Wessex used to be done by Ann Davis. She was a lady. She used to book the case whole day, and he's mentioned 11 hours. These are long surgeries, lengthy procedure. And if the anesthesiologist does not know his homework and the knowledge where is he going to work, what structure he's going to touch, it means patient won't be safe, surgeon won't be working well. This is a schwannoma, which vestibular schwannoma, which he mentioned. It comes to all the brainstem, to the basic nerves, vital for life. And all these side effects, they will happen, bradycardia, but does not mean that I have to close up and go away after 11 hours. You should deal with it. You should know. You should anticipate beforehand. You know, this lady, she might end up with bradycardia, tachycardia, hypertension, have all kinds, because he's working very close to brainstem. And he mentioned already, brainstem was compressed and edematous. So we should know before we go. We should know our book. We should know the patient. We should expect. We should prepare things for a very lengthy procedure, all-day procedure, and we should protect the patient for that and prepare ourselves. Bleeding, as he mentioned, but does not mean that after 11 hours, close the lady, take just a chip from the tube, and ask her to come back again. This is not acceptable at all. It should not happen. With all due respect. Sometimes, although we've done several cases, Dr. Ibrahim, I think also we should mention about the consent, which is nowadays in all hospitals, it's the consent is a must. And the consent, probably sometimes we should look and discuss with the surgeon, see them MRI, discuss with him. These people, sometimes they need tracheostomy because they will lose as well the reflex of aspiration. They might end up with aspiration pneumonia, even worse. You protect them. Tracheostomy could be temporary, could be permanent. So we should discuss all these options with the consent prior to surgery, prior that day of surgery, 2 days, 3 days earlier. See the patient and see what's going to happen, because we know he's going to work in brainstem. We should ask his opinion, where's the tumor? How much is brainstem is involved, edema, etc., etc. And probably the patient will tell you from signs and symptoms that he's already having problem with his swallowing, protecting his lungs, coughing, gag reflex, etc., etc. So we should anticipate, and if we anticipate this, I think we must inform the patient, our relatives, that this patient might end up with tracheostomy in intensive care, probably temporary, probably permanent. So we should prepare all these things. Position, it's I mean, as I said, this is our nightmare all the time. It's a lengthy procedure, all the time it's a lengthy procedure, and you have to do this operation in a patient who is going to be in a sitting position. I mean, all of you guys, you're sitting in this chair for about an hour and a half, you start have aches in your butts here and there, and your back, hands. Could you imagine if somebody who is fully anesthetized, has no reflexes whatsoever, and he's sitting in a chair? And to make it even worse, some pens, أخونا العزيز بحط هون 2 pens holding him, مش عارف إيش. So it is our true nightmare as me, as an anesthesiologist. Our most nightmare sitting position and as I said, it's lengthy procedure, hours, 11 hours, 14 hours in a sitting position. So we have to take all precautions for sitting position to maintain that patient after 14 hours. We're going to send him back to recovery or intensive care afterwards in good shape. We have to protect everything, his nerves, elbows, groins, eyes, nose, etc., tongue, anything. You should think him from head to toe to protect him, because it's a very, very lengthy procedure. Most common things would happen, as I mentioned in the past, air embolism will happen in 90% of patients. All sitting position, it will happen. But clinically, luckily, it's only about 20-25%. To see clinical side effects of air embolism, you need more than 0.25 ml per kilogram, a quarter ml per kilogram body weight. Then you will see a clinical manifestation of air embolism. But most of air embolism, they will be insignificant in volume. They will have some effect, but they will not have clinical effects to affect the patient to see in your monitors. But 90% of patients, they will end up, because he's going to operate in bone. Bone veins are open, as you know, and they will suck the air immediately. So monitoring, continuous monitoring, minute by minute, second by second, it's vital. Otherwise, patient will just go, and then tell the patient has this patient bradycardia, systole, sorry, but whatever you've touched and the patient is gone. If you are not aware, I'm monitoring this minute by minute, second by second, you will lose the patient. Treatment of air embolism, we've had quite successful. I don't remember any case, to be honest. I've been working for a long now in anesthesia field. Sitting position, Dr. Ibrahim, probably, I never seen a neurosurgeon work sitting position like him, to be honest. I can't remember a single case we have abandoned or we stopped an operation or end up with morbidity because of an air embolism. Because you have to have your central line, you have to check your central line before you start the operation in the right place, in the right atria, and you have to check and aspirate. My colleagues there, they work with me. Try the central line, aspirate well, aspirate in good syringe, 50 ml syringe there, and when it happens, we just aspirate. And we do aspirate sometimes large volume of air, 80 ml, 60 ml, 100 ml. You aspirate it very well, and just will do Valsalva maneuver, push things up, and fluid, he will soak the whole thing with the fluid to stop air coming, more air coming to the right atrium, and usually will carry on with the operation. I can't remember.
How do you detect air embolism?
Very good question. How we detect air embolism? First sign, we detect embolism in capnography, and that it takes you by seconds. Capnography, as I mentioned in the past, 40 millimeter mercury on your monitor. A neurosurgeon will go down probably 38 to 36 for the brain to shrink a bit to help him, make the brain more relaxed. When air embolism happens, immediately the CO2 goes down because there is no gas exchange in the lungs. And when you notice, immediately, and for the surgeon, try to make whatever you do with the position, soak the wound with saline, and we start aspirate, make Valsalva to squeeze the air in its place, not to let air go in the circulation, and start aspirating air. I can't remember a single case, to be honest. We have morbidity or mortality, or we have to stop the operation because of air embolism, although it's quite common.
Thank you.
Please. I just have to tell the international audience that you are a medical legal expert, so I would like your opinion about these cases. Dr. Mu'min Al-Hadidi.
I'm senior medical legal consultant. I'll speak in Arabic to make it clear. الموضوع الآن في عنا قانون في نقطتين مهمة. النقطة الأولى اللي فيها ستاندردز. النقطة الثانية فيها الخبراء، اللجنة الفنية. الخبراء هلا صاروا نوعا ما يعني نقدر نقول إنه هذا الخبير يستطيع يحكي عن هذا الموضوع. لكن الستاندردز أنتم بدكم تحطوها. أنا حكى الدكتور معاوية إنه لازم نشوفه بالأربع أيام. مين بيحكي لنا؟ أنا أنت بتحكي لما يقول في خطأ ما انشاف إلا قبل اليوم ما حد بيقدر يحكي. الآن the time has come to lay out good practice standards for each field, for each subspecialty. فإذا ما انعملت standards اللي إحنا نسعى إنها تكون ناخذ تبعون ال WHO اللي بتنحط لأفريقيا زي السويد، لازم على الأقل المستشفى نفسه اللي أنت فيه حطوا standards وبصيروا مثال يقتدى به في للآخرين. حط standards ولازم يشوفوا الانستيتيست قبل 4 أيام لازم ينعمل هيك كذا كذا كذا. وانا لاحظت في الكونسنت فورم رائع، لانه انت عمالك برضه بتصوب الخطا لمين، وايضا تحمي نفسك من اي واحد يقول لك انت اخطات.
من الذي كتب الكونسنت؟ في غلطه ابداعيه كبيره.
الموضوع المهم هو ستاندردز، لازم تنعمل ستاندردز. ويمكن حتى ما نضل نجلد نفسنا ونحكي على غيرنا، ابدا بالستاندردز هون في موضوع النيوروساينس.
بدي أسألك, as you are standing, this patient had 2 surgeries in another country and they are failed surgeries, and she came my way. Do I have the right to say I don't want to do the surgery?
You can say that.
So doctor has the right.
But ethically, if you can do it,
but she can go somewhere else. Sure.
لكن from ethical point of view، لكن
ليش ما يقدر يقول انا ما بقدر اعمل؟ لا ما بقدر لانه في شوي.
Sure. This is. I want to put you in the dilemma of the situation I found myself in. This is a young lady of 29. She's looking to me as a savior, and to take her is to actually take all the faults and mistakes of the previous surgery. So this is the dilemma, and he or she makes your life difficult in doing this surgery. So why should I do it? I agreed to do it because she's a young lady. I wanted to help her.
The MRV showed total improvement.
Absolutely. And sure, listen to this. We asked the surgeon there, give us the venogram. It was not there. Even we asked for the video tape, and we were refused for that. Now, I have to mention to the patient certain things. Hearing is lost, so it is lost. What about facial nerve? It's 100%. I cannot save your facial nerve. No way. I'm not magician. Even Magician cannot save your facial nerve because this is a large size. This is a redo surgery. So adhesions will cause this. So you will have facial nerve, and accordingly, you will need some plastic surgery to be done later on. And the complications. This is a very major surgery. It can kill patients. It can maim patients. So we have to be honest with the patient and say, you may have infection, meningitis, bleeding, basic vital signs and functions of a brainstem, which can cause paralysis, coma, or even death. This is posterior fossa vestibular giant schwannoma surgery. So I accepted the responsibility out of passion for the patient.
And this has to be labeled as high risk
Yes,
operation.
exactly. By us and by the anesthetist at 50% risk. So just take you through the anatomy, and then you can find and imagine the fear that is inserted in us. We are going here. This is the skull base, this is midline, this is the right side, and this is the left side. We are looking from inside. This is the trigeminal nerve and Meckel's cave. This is sixth nerve in the Dorellis canal. This is internal determinatus with 7th and 8th. This is jugular foramen with glossopharyngeal, vagus, and accessory. And here are the filaments of the hypoglossal. You are walking here. Trigeminal, vestibular, and facial, lower cranial nerves. Of course, you will be dealing with vertebral, basilar, etc. So if you look from inside, this is anterior, this is posterior, and we're looking at the temporal bone from inside. This is the squamous temporal bone, this is petrous, this is the mastoid, and this is the sigmoid going into the jugular vein. So this is the internal determinatus. And if you divide it into 4 segments, you'll find the facial nerve here in the most anterior superior. Underneath it is the cochlear, behind it is the superior and inferior vestibular. And the tumor is arising from either the superior or inferior vestibular. It is not from the facial nerve or cochlear nerve. That's why it is called vestibular schwannoma and not acoustic. And this is a cadaveric picture from a cadaveric course which I held. And you can see the trigeminal nerve there. This is the vertebral basilar. This is the ICA going into the internal determinatus. jugular vein. This is magnified view. Facial is in front, anterior. Vestibular is behind. This is the middle ear. This is the mastoid. You just can't do this surgery if you don't, or you master the anatomy of the temporal bone and the anatomy of the posterior fossa. Obviously, the surgeon who done the surgery has none of this. And I just don't know how he or she found the courage to go in and do nothing. So, when you put the patient in the sitting position, that's what you will see. This is the 7th and 8th going to the internal meatus. This is glossopharyngeal, which is single filament, vagus, which is multiple filaments, and this is the accessory made of cranial part and the spinal part. So spinal accessory, cranial accessory, vagus, and the glossopharyngeal. You are going there, and you have to see these things. Those veins are important, those arteries are important. So sitting position, I'm proud to say that we are very much leading this area in the world in the sitting position. Of course, Majid Sami is the #1 in the world in the sitting position, but you have to have a surgeon who knows the anatomy, and most importantly, an anesthetist who has the courage to put the patient in a sitting position and accept all these complications. So we use the microscope, of course. I am sitting, the patient is sitting, and we'll go this way. On the left side, we use this lazy C-curve incision. We can use the navigation if we like, and we do this under monitoring of all the cranial nerves. So you will come to the posterior fossa like this. This is right cerebellum, this is left cerebellum, and you want to go there. So if you go like this, here, you will go to the trigeminal nerve. If you go like this here in the middle, you will go to the facial and vestibular. If you go here, you will go to the lower cranial nerves. And each has its own neurovascular bundle relationships. And once you are there, you can drill the internal determinatus to see the nerve like this. And when you drill, this is the facial and vestibular going into the internal meatus. If you want to drill this, you have to be careful that you don't have what we call high jugular bulb that reaches there, and then you will damage it. In a sitting position, patient will die. So when you drill it, you drill the posterior lip of the internal meatus and the superior lip. So you are drilling towards the tent. You don't drill this way. And you drill with the side face of the drill. And then you can see the tumor. In this case, this is a small schwannoma, intercanalicular. Or in this case, this is a large schwannoma that comes out. So you can see the origin of the tumor. Let's see the surgery. So sitting position, we are working on the left side. So midline is here, right side there, left side here. And I have retracted the cerebellum. And look at this. Mucky, it's all amalgamated together. You don't see it. You should differentiate the tumor from the brain tissue. Here you can't. And that's the risk. You can't differentiate the color and consistency because of the adhesions. Obviously, they had a bleeding here. That's what they had the bleeding. They had a bleeding at the junction of the transverse sinus with the sigmoid, and they have put a big plug of muscle to prevent the bleeding. And when they went in, again, they had bleeding. So what they have removed is this little chunk of the tumor there. The tumor is still there. How he or she dare to tell the patient that we have removed the tumor, I have no clue. Here we want to see the most important thing, the vagus nerve, damage of which will end the patient on a ventilator. So you have to work your way slowly, gently, but efficiently, and you don't look at the clock at all, no matter what it takes. Here I want to protect the vagus. I want to protect the vagus, I want to protect the brainstem, I want to protect the vertebral, I want to protect so many things. Here I'm trying to find the plane of cleavage between the tumor and the brainstem. And I use the dissector, or I use the forceps, to take the arachnoid towards the brainstem. because underneath the arachnoid is the blood supply of the brainstem. Damage the blood supply of the brainstem, patient will not wake up and he or she will die. So what we call is debulk the tumor, dissect around the tumor, drill the internal detonators, and then you can succeed. We use the ultrasonic aspirator to take the tumor from inside, and زي الكوساية زي المحشي. You want to evacuate it from inside so that you can go around it. Here I'm trying to find the pica, and I will find it. It's there with the vagus nerve.
It's well encapsulated.
It is, vestibular schwannoma is encapsulated, but once you have done surgery and there's a bleed, then things will get you don't know where you are. Usually they are, yes. But you are working in a small space, posterior fossa is a small space, and 4 centimeter diameter tumor makes your life very, very much difficult. So here I'm finding the pica. Look at the adhesions because of the bleeding. Pica with the vagus nerve here. So this is pica, and this is the vagus. This one. So piece by piece, slowly, gently, under the microscope. Imagine there are people in the Middle East who would do this without microscope. And they say, I have a good vision. Those who use a microscope are all surgeons who need the microscope to see, which is, I don't want to comment on that. But again, what is the truth in this? Here, I'm taking the arachnoid towards the brainstem, and here, in this area, is the trigeminal nerve. The beauty of the sitting position is that blood and CSF are just flowing down, and that's a good thing. By the way, air embolism can happen even if the patient is in the supine position or the prone position or lateral position. It is your technique. Air embolism can happen from skin, from muscles, from subcutaneous tissue. It is more in the sitting position, but if you know what to do, then there is no problem. So you have to have good anesthetism. This is trigeminal nerve. So I'm just pushing it away. Again here, it's a really painstaking procedure, needs patience, needs that you trust yourself, trust your team to do it. Now, during surgery, I am trying to observe any facial function through the monitors and through the cranial nerve observation. You just cannot find it. In spite of that, I knew I can't find it. I was trying to, but I just couldn't find any filaments that I can save. Again, using the ultrasonic aspirator, which emits ultrasonic waves, and it will valgrate the tumor. Because all this is transmitted to the screens in the operation room. The anesthetist is watching, the anesthetist assistant is watching, the scrub nurse is watching, the surgical assistants are watching, and the visitors are watching. So you are doing your job under the vision of observers. And you cannot cheat them. You cannot say, I have removed the tumor, or I have done this or done that, because they can see you. And this film is going to be given to the patient family and herself to see at their leisure and see that they have removed the tumor. This is evidence-based medicine. It's not just talking. I have removed the tumor and you have done nothing, like our friend. So that pulsating is the pons. And here is the cerebellum. The retractor is just barely holding the cerebellum from just rolling back. End of surgery? No. I know there is a big chunk of a tumor, according to the MRI, inside the internal meatus. So I have to drill it. To use the drill near the brainstem, near the vertebral artery, is something. You just cannot do it unless you have done it in the cadaveric lab. But some of the neurosurgeons here, they just take the drill if they dare to, and they just drill anything. So we drill the superior lip and the posterior lip of the internal hiatus, and all the time there is some fluid to prevent heat damage to the structures. And I use this carrot to take any tumor inside the canal. It will not be complete surgery if we leave these tumors inside. And how far would I go? I can go that I know how the distance that I can go in before reaching to the vestibule inside the inner ear. So each and every ear is the gauge that I know how far I can go in. Again, note the bones being pulsating. The ENT are the best drillers in the world. We haven't learned drilling from them. And it's an art that every neurosurgeon should have. So, nice pulsating. Now if I remove the retractor, everything will, removing these, cerebellum is just being held lightly by the retractor. You don't have to damage the cerebellum. Saline wash all the time. Putting Surgicel, which is hemostatic material. And I want to fetch some muscle from here and put it inside the internal detritus to prevent an CSF leak. This is biggest.
To prevent what?
To prevent any CSF leak from the inner ear. It will go into the middle ear and from there into the station tube, and they will have CSF coming. This is the glue that we put on the muscle to prevent any CSF leak. I'll show you, I've just removed the retractor and the brain is just okay. Okay, histopathology.
This case was typical of vestibular schwannoma. You can see spindle cells going in tracts, and some areas more cellular than others. It's hypocellular and cellular. You can see it's vascular, and the blood vessels tend to have hyaline material around them. I'll show you more. Yeah. This is very cellular area, and here's again very cellular area. You can see the spindle cells in fascicles. And you can see vascular and filled with blood vessels. I'll show you more. You can see here how these areas are very cellular, and this is more hypocellular. The cellular areas, we call it Antoni A areas. The hypocellular is usually Antoni B, and this is typical for schwannomas. And you can see blood vessels, they have hyalinized material around them. Again, here's very cellular area with a lot of blood vessels, and again here very cellular area. They go in tracts. You can see typical, this is Antoni B, hypocellular myxoid area, and this is Antoni A, cellular areas. This is blood vessels, hyalinized. This hyalinization usually indicates the chronicity of the region. Very cellular area, and this is myxoid areas. See how the typical hyaline material. When you see this in a tumor, this is typical of usually, it's one of the features of schwannoma. You can see some cells were hyperchromatic, and this is also allowed in schwannoma. Usually when we see hyperchromatic cells, we get worried, but not in schwannomas, because this is indicating an ancient changes. We call it ancient schwannomas. It's a long history there. This is very typical also, very cellular with the hyalinized material. You can see how the tumor cells are very cellular with some hyperchromasia in some of the cells. See, typically they are in tracts, in fascicles. This is the nerve structures, and this is less hyalinized or fibrosed areas in some areas of the tumor.
This is, you can see, typically any nerve sheath tumor, or usually they have the these are nuclei, and nuclei are wavy. يعني مثل الطائر أو مثل الموجي. This is typical when you see something like this. Sometimes we don't know the origin of the tumor. You suspect it is highly to be a neuronal origin. You can see the ancient changes in some of the cells. Again, you can see some ancient changes. So the cells are in bundles, in fascicles, in going like cartwheel appearance. Again, you can see this is very hyperchromatic cell, worrisome when you see something like this in other tumors, but it's acceptable for benign tumors like schwannomas. You can see here the blood vessels and the hypovascular. You can see some inflammatory cells. It's common to see inflammatory cells, especially mast cells in schwannomas. This is typical. I think most of these are mast cells. We don't really pay much attention to them. This is just if you are in suspicion, what is the diagnosis? You can do a CD117 or Giemsa to stain these mast cells. The differential in this case, as for pathologists, is between schwannoma versus neurofibroma versus meningioma. And you can see actually the morphology is more between meningioma and schwannoma. This 100, when it's positive, indicate it's a neuronal origin tumor. You can see this 100 usually has both cytoplasmic and nuclear. The nucleus is hyperchromatic, it stains the nucleus, and it stains also the cytoplasm. This is one of the stains that stains both the nucleus and the cytoplasm. This 100 stain. Other stains usually they select either to stain the nucleus or cytoplasm. Epithelial membrane antigen, we did it to exclude completely meningioma. It's completely negative. You can see it's all negative. I think we did progesterone stain. B53 was completely negative, indicating benignity of the tumor. K7 was negative. And we did also progesterone was also negative. Okay, this is progesterone stain, progesterone also positive in usually in meningioma, it's negative in schwannoma. I usually like to have double positive markers, double negative markers if available in this tumor, and this is confirmed that this is a benign schwannoma. Okay.
Some people may say this is luxury information, this is a basic information. I was asked in my board exams about antennae A and antenna B areas of schwannomas. So it's a basic, important piece of knowledge. So this is a vestibular schwannoma. She woke up on table, 15/15. Nobody is allowed to go on a ventilator at all in our cases. All the cases that were done with Dr. Mao, Dr. Varas, patient must wake up on table. No patients are sent to the ICU on ventilators. And this is the following day, MRI. Total radical excision. And we did not do anything to the hydrocephalus. We did not put a shunt. Shunt is a disease of the Arab world and third world countries. Blood figures will come down. Look at this. Brainstem is intact. No ischemia. No damage. And this is where we were. She developed some CSF collection in the wound. We treated it with repeated lumbar punctures. And this is the end result. This is her discharge summary. Detailed discharge summary that you can take anywhere in the world around. And this is herself. I just want to show you this beautiful young lady. To save her life is something, it's an achievement. It is the best reward ever you can get. To send her back to her family, to her mother, to her kid. She has only one kid called Sakar. She was always remembering him all the time. This is something. So that's it. Any questions, any comments? Please, Doctora.
أنا أقدر فيك الإصرار على معرفة التشريح هو باب النجاح. أذكر في حضارتنا العربية الإسلامية الرازي عندما عمي بسبب الكاتاراكت أتاه من يجري له العملية، كانت عملية تسمى القدح، كان ضغط على العدسة فتسقط كما يسقط الحجر البئر فيعود المريض يرى. أول ما فعل الرازي وهو شيخ الأطباء قال للجراح اشرح لي عضلات العين، فعندما فشل قال لن أسمح بطبيب يجري لي عملية وهو لا يعرف التشخيص. أنا أخبر في معرفتك العظيمة للتشخيص.
Here he would have passed the board examination.
Yes.
1400 years later.
We were speaking, I must mention this, we were speaking about the complications of sitting position, right? And you have seen one of the complications. He was sitting there and he just spilled the cup of coffee in his lap. And you should be awake. Any comments, any questions, please do. If nothing, thank you very much. Great to see you.